Welcome to the Advancing PAH Care video series. This series includes key opinion leaders who discuss new information in the 2022 ERS Treatment Guidelines for Pulmonary Hypertension and how these recommendations can be incorporated into clinical practice in the U.S. Some of the topics to be covered in this series include risk stratification, the right heart beyond pressure, ERS treatment algorithms, and individualized patient care. With support from UT, the PAH Initiative provides non-branded disease education for the PAH community. The initiative worked with PAH experts to identify the content for this program.
Hi, I'm Benza. I'm a professor of medicine at the Icahn School of Medicine at Mount Sinai in New York City. I'm also the network director for the Pulmonary Vascular Disease program at Mount Sinai Heart. And I have the pleasure today of being joined by my colleague and long-term friend, Dr. Valerie McLaughlin, to discuss risk stratification in the context of a video series on the evolving management of pulmonary arterial hypertension. Val?
Ray, thanks so much. It's a pleasure to be here with you today. I'm Valerie McLaughlin. I'm a cardiologist and endowed professor of medicine at the University of Michigan, where I also direct the Pulmonary Hypertension program. I'm really excited to be here today to talk about risk stratification with my dear friend Ray. Now, Ray and I have been doing pulmonary hypertension for a long time, and there's been a lot of progress in patient care and a lot of progress in what we've learned about risk stratification, including so many sentinel publications that Ray has led from the REVEAL study. Now, when we think about risk assessment, we really need to concentrate on objective multi-parameter risk assessments. We never rely on any one variable in assessing a patient's risk. PAH is a complex disease. We really need a big picture of the patients. The risk scores help us provide a consistent objective method to follow the patients over time. Really much better than assessing one thing like functional class or on relying on Gestalt, just the eyeball test. And it helps us establish treatment goals. We have very well established data now that tells us our goal should be to get a patient to low risk status. We know that their prognosis is going to be much better if we get them there. And using risk assessment tools can help clinicians alter the treatment strategies if a patient is not at low risk. And follow-up assessments need to be done regularly. Every single encounter with the patient is an opportunity for risk assessment and adjustment of therapy. So, Ray, why don't we start out by talking about what risk stratification tells us about the patient prognosis and treatment goals?
Well, it could tell us quite a bit. I would love to remind everyone that, this whole evolution of risk stratification really stemmed from the work that you did such a long time ago and published in that beautiful article in JACC where the first risk table was published. And I always remember that table and looking at it and saying to myself, well, it is better to use more than one variable at a time because it really paints a better picture of how a patient is going to do with this disease, particularly because it's such a progressive disease. And I think that was one of the clues that helped me derive the original REVEAL risk score. So I thank you for that.
You're most welcome.
So risk stratification, as we know, helps us predict both mortality and morbidity in patients with pulmonary arterial hypertension. And all the contemporary risk equations and calculators were derived from registry data, from large cohorts of patients that we followed in the United States or in Europe, including those in REVEAL in the US or Compara, the Swedish registry or the French registry in Europe. And all of these have been used to estimate survival. And it's important to understand that the products that came from these registries or these risk tools that evolved from these registries have some key differences that reflect the area of the world where they were derived from. So with that being said, how do the patient characteristics of these registries in your mind apply to the patients that you see in practice?
Yeah, I think it's a great question, right? Because we think of PAH, and sometimes we think of, the clean PAH that we enroll in clinical trials, and that's a very clean population, but it's not what we see every day. And so the registries really reflect more real-world data. The Reveal registry is a U.S. registry, so it really is reflective of the patients that you and I see every day. The French registry, they actually are a lot tighter on their entry criteria, and in many ways it looks more like a clean-cut Group 1 PAH population. They have some heritables, they have some drug and toxin induced. The Compara registry actually is older and with a lot more comorbidities than what we see in the U.S. So they're actually three very different registries.
So thanks for going through those individual characteristics of those registries. I think that's important for the audience to recognize. But let's continue. Risk status is important in setting goals of treatment, in establishing treatment, and for monitoring plans, and determining when treatment adjustments may be needed. The ESC and ERS guidelines recommend a goal of low-risk status for all patients with pulmonary hypertension, and I know that I practice that and I treat to low risk. Patients at low risk have the highest survival rates at 5 years, and even those at intermediate risk, we have to remember that their survival is less than 95%. That's really important. So just because someone is intermediate risk doesn't mean we can leave them alone. That's actually a very important group that we need to focus on and to drive them to low risk. Because a stable intermediate risk doesn't mean they're risk-free. They are still at very high risk of death. So getting those clinically stable intermediate risk to low risk is key. And so I want to make sure that people understand the difference between clinical stability and low risk. It's not the same thing. We want to treat to low risk. It's really essential also, I think, to avoid underestimating risk in this population. Pulmonary hypertension is a rapidly progressive, deadly disease. You don't want to make a mistake with that first discrimination and that first calculation of their risk, because if you do, you won't use the same intensity for that initial therapy as you would, and someone can get hurt by that. We need to use these comprehensive risk assessment tools that have very good discrimination. So Val, how would you describe how the treatment guidelines characterize baseline risk assessment?
Yeah, sure. This is really, really critical. Remember, when we're first meeting a patient and making a diagnosis, we're doing a very thorough evaluation. We have more data at that time than we probably have at any other time. And so we can do a comprehensive risk assessment that includes everything we do in clinic, like hall walk, labs, and such, but also echo, right heart cath, sometimes MRI. We have a lot of information. And so going back to that risk stratification table, the low, intermediate, high, it's been interesting to see what's been added in the ESC ERS guidelines this year. So there's some new information about TAPC, PAPC, about right heart function. So the TAPC divided by the pulmonary artery systolic pressure gives us an indicator of RVPA coupling, which we think is very, very important in pulmonary hypertension. There are some additional MRI parameters added. And so really, it warms my heart to see more indicators of right heart parameters in the risk stratification table. And Ray, you and I are cardiologists. We are very passionate about the right ventricle. Tell me your thoughts about these additional parameters.
Yeah, I think they're invaluable. And, all the contemporary stratification schemes that we've developed, we always knew we were going to have to add additional factors. We have advanced so much in what we can do now with our imaging parameters that we can get much better quantitative information from them. And I think that needs to be incorporated into our risk stratification tools. Because if you think about it, all really the variables that we have in all these scores really describe how the right ventricle is faring in the face of this very high afterload that is characteristic of this disease. So why not have the most direct assessment of the right ventricle in imaging parameters?
Yeah, absolutely. Now, it doesn't mean like if you don't have one parameter that you can't calculate a risk score. You still do it. But I do think it's important to have all that data at baseline. And remember, low risk status is the treatment goal, and we have to reassess risk every time we see the patient. The intermediate risk group, is a wide range. It has a 1-year mortality between 5 and 20%. So that's a really wide range. And it really emphasizes why the goal is low risk. So Ray, you've really made so many important contributions to the literature with REVEAL. We've learned so much from the work that you've done. Why don't you tell us a little bit about the REVEAL risk scoring methods and, describe how the ESC-ERS updates align with the approach that you took in REVEAL?
Yeah, thank you. I think that's a really important thing for people to understand, that these algorithms are very similar. It's the way that the multivariables were put together where the biggest differences are. In REVEAL, we used more of a statistical approach where we use statistical weighting of the variables so that we know how one variable relates to the other variable very tightly. And that allowed us to develop algorithms with very high discrimination, meaning that we're very likely to depict how a patient will live or if a patient will die using these statistical modeling that we did. But the parameters are very similar, and many of them are in the European risk table.
So, Ray, that's a really great description. And of course, it's wonderful to have all that data at baseline and do the full comprehensive assessment. Now, let's talk a little bit about how you use REVEAL 2 in follow-up of patients, right? Because that's really critical too. The goal is getting to low risk status. So tell me about how you incorporate that into the care of the patients.
Yeah, one of the things that we were taking into consideration when we did derivations of the REVEAL 2.0 score is we had to take that into context of a very clinical, busy environment. And so we developed an abridged form of REVEAL 2.0 called REVEAL Lite. And abridged in meaning that we are utilizing only the changeable variables in this scoring system as opposed to REVEAL 2.0, which had immutable risk factors in it like gender and age and the type of pulmonary hypertension. But you only use the changeable risk factors, the vital signs, the renal function, the natriuretic peptide levels, the walk distance, and the functional class when you make that determination. So REVEAL Lite 2 provides an accurate discrimination between risk with fewer variables than REVEAL 2.0 does. And then I mentioned earlier, the 2022 guidelines present a similar model in the 4-strata model. And I'd like to ask you, this model, which was derived in part from REVEAL Lite, how do you think that fits in and to our overview and how we approach the patient's risk status?
So when we think about how the ERS ESC guidelines initially did risk, there were only 3 risk strata. We had variables that were low, intermediate, and high risk, and you calculated the score based on the variables that you had, low, intermediate, high. So that intermediate risk group is big in terms of percentage and big in terms of how we might approach treatment. So the group from Compara kind of looked at this and said, maybe there's some way to discriminate this a little bit more. And so they took their registry, over 1,600 patients, and they divided them into 4 groups rather than 3, a low, intermediate, high, and high. And they used cut points derived from various registries for 6-minute hall walk, functional class, and biomarkers. So the 5-year survival between those intermediate low and intermediate high groups is 67% versus 47%. It's a big difference. So I think it's really practical in terms of explaining things to patients and in terms of making treatment decisions. Now, REVEAL took a little different approach to that. Can you tell us about that?
Yeah, thanks. That's a really key piece to really understand about the way REVEAL is supposed to be used. REVEAL is a continuous scoring system, but using it as a continuous measure where you have a score from 1 to 21, you can get a really nice separation of the various risk levels within that intermediate risk. It's always been there, and it's a good thing to recognize that you can get that level of discrimination in that intermediate group using the continuous scoring system of REVEAL.
let's change gears a little bit. So can we talk a little bit about some of the other aspects you consider when you decide what to do, how to manage your patients with pulmonary arterial hypertension?
Sure, I think that's a really great direction to go in. I think we need to remind ourselves that our treatment goal is to achieve low risk for as many patients as we can do, because we've demonstrated better survival is associated with this low risk status. And that's my goal, that's your goal, and that's what we should be teaching all of our colleagues who treat these patients in the community. All risk tools have advantages and disadvantages, and none of them can perfectly predict prognosis. So there is better need for integration of other tools into these parameters, particularly imaging variables, so that we can better reflect on prognosis and make better predictions. So these are a couple of my suggestions. So Dr. McLaughlin, is there anything that you would like to add to this?
I think we feel both very passionately that, we are dedicated to taking care of PAH patients, and, but we want to work with their local docs, and, it really takes a village to take care of the PAH patients. And then the other thing I want to acknowledge is like all the people that help us do this.
Yeah, those are really valuable points. So I want to thank you, Dr. McLaughlin, for sharing your incredible experience and providing your perspectives on how risk stratification can be useful in clinical decision-making at diagnosis and throughout treatment. The next video in this series, and you might want to watch that, really builds on the story that we've created by focusing on right heart dysfunction as an important indicator of disease status and patient prognosis. In the meantime, I'd like to rehash some of the key points that we made on this talk today, and to leave our audience with some important caveats. First is that comprehensive risk stratification is an essential part of patient management. Early and frequent risk assessment provides a timely indicator of treatment response and whether adjustments to treatment plans are really needed. As we mentioned earlier, every opportunity to risk stratify is an opportunity to help a patient get the treatment that they need. That these treatment modifications should be based on objective risk stratification results, not just on clinical gestalt. And a PAH requires a proactive management scenario. It's an entire village. So collaborating with PAH specialists and experts can really ensure that patients are optimally treated. So I want to thank you again for being here with me today, and it's so great seeing you back here at the University of Michigan.
Ray, thank you so much. I always learn something every time I talk to you, and I really enjoyed our conversation today. Thank you.
Fantastic.
Thank you for watching. This program is part of a series of videos about how PAH management has evolved in recent years. Topics covered in this series include the importance of hemodynamics, the role of risk assessment, the PAH treatment algorithm, and considerations for the treatment of PAH. For more information on PAH, please visit resourcesforpah.com.